My name is Sang Tran. I'm a third-year medical student at the University of Maryland. In this module, I'll be going over the cranial nerve 3 palsy. In this module, I will go over some basic background information, the causes of cranial nerve 3 palsies, the different presentations, exam findings, diagnostic workup, and treatment options for cranial nerve 3 palsies. Cranial nerve 3 innervates the superior rectus, medial rectus, inferior rectus, inferior oblique, and the levator palpebrae superioris muscles. The levator palpebrae superioris muscle functions to elevate the upper eyelid. In primary position, the actions of the superior rectus are elevation, encyclotorsion, and adduction. The superior rectus is best tested in abduction, where it functions primarily as an elevator. The medial rectus muscle adducts the eye. The functions of the inferior rectus are depression, excyclotorsion, and adduction. The inferior rectus is best tested in abduction, where it primarily acts as a depressor. The primary action of the inferior oblique is excyclotorsion. Secondary actions are elevations and abduction. The inferior oblique is best tested in adduction, where it functions primarily as an elevator. In addition to innervating the various extraocular muscles of the eye, cranial nerve 3 also carries autonomic parasympathetic innervations to the ciliary muscles, which controls the shape of the lens, and the sphincter pupillae, which constricts the pupils. A key feature of cranial nerve 3 is that the parasympathetic fibers travel in the periphery, while the motor fibers travel in the center of the nerve. Thus, the parasympathetic fibers are more prone to compression, while the motor fibers are more prone to ischemic damage. Cranial nerve 3 palsies are classified by two criteria. One, if it is a complete or incomplete palsy, and two, if it is a pupil-sparing or non-pupil-sparing palsy. A complete palsy will show complete limitations of the extraocular muscles innervated by cranial nerve 3, while an incomplete palsy will show only partial limitations of those extraocular eye muscles. Pupil-sparing palsies will show equal pupil sizes bilaterally, while non-pupil-sparing palsies will show a dilated pupil in the affected eye. Cranial nerve 3 palsies can occur as a pupil-sparing or non-pupil-sparing palsies due to damage to different parts of the nerve. As mentioned earlier, cranial nerve 3 carries parasympathetic fibers in the peripheral, while the motor fibers travel in the center of the nerve. In non-pupil-sparing palsies, oftentimes a posterior communicating artery aneurysm compresses on the nerve, damaging the peripheral parasympathetic fibers, while in pupil-sparing palsies, the central motor fibers are damaged, oftentimes due to ischemia. Here's a quick overview of some of the cranial nerve 3 palsies that you may encounter. A complete pupil-sparing palsy presents with complete ptosis, with the eyes positioned downward and outward. Such a patient will be unable to adduct, depress, or elevate the eye. The affected pupil will not be dilated. This presentation commonly occurs due to ischemia of the central part of cranial nerve 3, most often caused by inflammation, hypertension, diabetes, high cholesterol, and/or smoking. A complete non-pupil-sparing palsy will present with the same features as a complete pupil-sparing palsy, but instead the pupil is dilated. This presentation occurs due to compression of the peripheral part of cranial nerve 3, most commonly from a posterior communicating artery aneurysm and rarely from a malignancy. Incomplete palsies are generally pupil-sparing. They present with variable limitation of the affected extraocular muscles with variable drooping of the eyelids. This presentation occurs due to ischemia of the various distribution of cranial nerve 3. In this clinical exam, you can observe that this patient's right eye demonstrates ptosis, or drooping of the eyelid in primary gaze. On right lateral gaze, we can see that the patient's right eye can AB duct, while their left eye AD duct, which is consistent with a normal exam. However, on left lateral gaze, we can see that while the patient's left eye appropriately AB duct, adduction of the right eye is impaired. This is consistent with a deficiency of the right medial rectus muscle. With respect to the vertical position of gaze, we can see that on upward gaze, the right eye is unable to elevate while the left eye is able to do so. In addition, we can see that on downward gaze, depression is intact in the left eye while it is impaired in the right eye. This shows a deficiency in the right superior and inferior rectus muscles. Taken together, this patient's examination is overall consistent with a complete right cranial nerve 3 palsy. Cranial nerve 3 palsy can be a sign of raised intracranial pressure. Therefore, a dilated fundoscopic exam should be performed in all patients to assess for swelling of the optic nerve. We will also need basic lab work such as a hemoglobin A1C, fasting glucose, CBC, ESR, CMP, and ANA to help rule out the microvascular versus inflammatory causes. A brain imaging using CT with contrast or MRI with contrast may be warranted to rule out the more serious causes of the defect, such as an aneurysm and malignancy. If an aneurysm is suspected, a follow-up CT angiography or digital subtraction angiography is needed to view the intracranial vasculature. This is especially important in non-pupil-sparing palsies. New-onset cranial nerve 3 palsy is considered an emergency, and patients should be referred to the emergency department once the diagnosis is made. Defects caused by mass effect should be managed by neurosurgery, while microvascular palsies often resolve within the first 3 to 6 months. Defects that remain after 6 months should be considered for strabismus surgery because the other form of treatment, such as prisms, are unlikely to restore an area of single vision.